was going to tell you about the knees is almost all knees are the same. Okay, you put a femur on, you put a tibia on, you put plastic in between, and then you can put a kneecap on it. Okay, most all of these have to be cobalt chrome. This can be titanium if you want to. One of the knee companies, which is kind of a nice addition, is a coating on this zirconium, so it's kind of like a ceramic, so it's a little bit smoother. Smoother means less wear. So this would be what a total knee would look like, where it articulates, does all of this fancy schmancy stuff. And here's what I tell my patients. If you were an engineer and I had the biggest orthopedic company and I challenge you, I want you to go to the basement and spend as many resources as you need, and I need you to come up with the shape of a femur that is good for everybody on the planet. Okay? And then we'll make just different sizes like nesting bowls. And that's a pretty big task because we know research-wise boys' knees are different than girls' knees. I know right knees are different than left knees, okay? And so this is what this engineer came up with, which is different than this engineer that came up with it, okay? And they're trying to fit everybody into this shape. And the most important thing about it is, what does this look like? What does this curvature look like? Because I'm a little taller than you guys. My curvature may be a lot longer. And what I've found is when I do a knee now with a custom implant, I don't have enough bone taken off that if it was tuna, I couldn't make a tuna sandwich. It's amazing how bone sparing it is. So that's what a total knee is. This is, I'm sorry I don't have it on a model. This is what a partial knee looks like. And so all it does is take instead of putting the whole thing in, we put this just on one of the condyles. You know, I can do that muscle sparing without cutting any muscle through a little 2-inch incision, which is kind of nice for the patient because they're moving around right away. And this is just the custom knee that we're doing where you're now getting 2 little inserts that you can put on so you can adjust that accordingly. These are all vitamin E enriched. The shape of the tibia, when you look at it from a bird's eye view, is different on everybody, and they match that perfectly every time they make a tibia. So you're using the whole surface area, and it's not so much that the femur fits top and bottom, they all do that, but the least amount of cuts that you have to do per patient is what I think makes the biggest difference in the world. So that's knees. Not a whole lot else happening in that world.
Why would I do a partial? Why would you do a partial?
You do a partial if you have it in your arsenal. I joke with patients. I'm like the U.S. Army. I can drop a nuclear bomb, or I can send 2 guys in to kill you, whichever one you want, or something in between. Mm-hmm. If you do a partial and you have isolated arthritis on the knee, because if you see somebody that's bow-legged, it's like they're wearing the inside of their knee, but the other thing is they're protecting the outside of their knee. So if this person this is their natural knee, they're wearing this like crazy, but this is virgin territory. So I can do it. So we designed, I didn't design it, I was kidding you about that one. 50 years ago they designed it with the idea you're too young to have a total, so we'll do a partial, 5 years later we'll convert it to a total. Guess what? If you do it right, they don't have to get converted. And you still keep them bow-legged. That's the thing that a lot of people don't understand. If anybody gets a total knee replacement, we put you a couple of degrees knock-kneed. When you do a partial, you have to be a couple of degrees bow-legged because I want all your weight on my implant, not on this future wear and tear area. So it's quick. And I struggle now in my office to do a partial because the difference between a custom and a partial now is so, it's hard to justify doing a partial. You're only in the hospital in a day. You're only in therapy for 6 weeks. You're getting bend better. A partial, I tell people I expect you to get 130 degrees. A total, I expect you to get 120. The totals are getting 135, 140 degrees. Mm-hmm. So it's harder for me to do partials now, but that would be the reason why.
Why do they still do knees that are not custom?
Oh yeah, customs
Why would
is.
you do a not custom?
Just because might be cost. I was on the phone with the insurance company yesterday about that. We don't want to approve a CAT scan. Well, I need a CAT scan if I'm going to do this custom knee. Well, I know, we don't usually do that. It's not been proven. I said, well, what I will tell you what's going to be proven, and I'll have a white paper I can give you in probably 90 days, is that it is saving you a fortune because you're only in the hospital for 1 day and you're not paying 3 months of therapy. And the girl approved it. But I think right now maybe 10% are custom. There's only a handful of surgeons doing the the custom implant one. But the custom jigs, I think most of the docs here are using custom jigs now for their knees. You have to wait 6 weeks. That's the other downside. You know, somebody's miserable. You got to wait 6 weeks to get it made.
Mm-hmm. Have to plan ahead. Why women more fractured hips than men?
Well, I think it's a lot of sexist stuff that goes on. I'm the man of the family. I work. I'm looking at all the women here that are working.
Yeah, watch what you say.
And so I'm not sitting at home eating bonbons, you know.
Mm-hmm.
So how do you, what is the biggest, treatment for osteoporosis? You know, exercise, pounding on it. I think women are frailer, but I can tell you, I tell it to my patients all the time, to the guys, I said, you better get some stretching going because your wife's going to outlive you and you will fall and kill yourself. Mm-hmm. And because if you're flexible, and that's what most women can be, they're more flexible than the guys, but the guys are stiffer bone. They have bigger bone density to begin with. Mm-hmm. You know, so you're starting with a bigger pool of losing bone. And we all know the frail men. We also know the guys that are, I tell some people, when you have to jump out of the airplane, jump on the back of your husband because his femur is so freaking strong. It's not going to break, it is not. You'll survive, believe me, But I think things are changing. I think, like you said, the fracture rate's going down because I think women are more participating. So I've been here 25 years. So, 25 years is now taking that 50-year-old that's 75. They've been on their, phosphates. They've, had their, calcium encouraged to take. They've been more active. They're probably working as opposed to 25 years before that. Maybe, the majority weren't working. I just want to be at home. I just got to not do a whole lot, So I think that's the biggest issue. And I think that's going to get smaller and smaller. Mm-hmm. So, anything else? Anything that I really want this talk for the newer nurses. I really wanted to gear it to make sure we include enough that they see it. How do I move this person? Why is this one different than that one? So that, again, if you can teach them fracture stability versus joint stability. Yes, you can throw that patient over your shoulder and take them out because their hip joint is stable. Don't let them put all their weight on it. Or the other way around, you have to be somewhat cautious with them because their joints are unstable. Well, thank you guys. Appreciate your attention.